Hi, how are you, friends? Are you Dr. Muhammad Kazafi, and you are watching Dr. Muhammad Kazafi Views. And there's a good morning, there's a morning, and good evening, there's a evening. I want to present a case of a subaxial cervical fracture, a real case which we treated. And I want to present as a case and some extra detail if possible I could transfer to you. I have a 24-year-old male was involved in a high-speed motor vehicle accident. Past medical history, he was diabetes mellitus type 1 and physical examination and is a sensory, there is a no sensory deficit, and or we can say the motor exam with the 5/5 strength in bilateral deltoid and bicep, but the 0/5 power in bilateral tricep, wrist flexion, and wrist extension, and both lower extremities. In the sensory point of view, I want to mention there is a sensory deficit in the both upper extremities and both lower extremities with sensory level at C7 T1 level, and sensory level, as you know, there is a C7 with no sensation below, and no rectal tone, and distended bladder can be palpable. I did the patient was received in the emergency room. Definitely your initial history, definitely trauma, and trauma is maybe definitely the cervical fracture, or with the cervical fracture due to the traumatic cervical fracture, but on the differential diagnosis you can say there's a neoplastic infiltration, either primary or metastatic disease, infectious disease, osteomyelitis, or post disease, or degenerative changes in an autoimmune disease, or osteoporosis with a metabolic bone disorder. Although I did the CT and a whole workup, CT scan, which is suggestive for the translation at 6-7 vertebra. And 6-7 vertebra, there is a translation of the more than 50%, and MRI shows also there is a translation over the C6 C7, and with the contusion in the spinal cord, but there is a canal compromise more than 50%, and other laboratory investigation has been done, and the routine lab CBC, wide differential chemistry, coagulation profile, CRP, C-reactive proteins such as ESR. If infection, we have to check, or we are suspecting. But although preferred imaging diagnostic tool, plain X-ray, AP, and lateral views of the cervical spine, then I did the CT scan cervical spine to assess the bony anatomy, and the reconstruction for the operative planning, MRI cervical spine to assess the CSF space, spinal cord proper, and disc, and the ligamentous structure. Contrast studies are usually only necessary when investigating infection or neoplastic etiology, but in here the patient was presented with a traumatic injury, and as I mentioned, there's a translation fracture of C1 to C6 to C7. Here you can make for the knowledge some classification. As you know, cervical spine fracture can be described morphologically as compressive burst flexion distraction, or as fracture dislocation type, in a classic way that the fracture elsewhere in the vertebral column are described. Several standardized classification systems have been attempted, though one are universally accepted and used at this moment, and this is the Allen Ferguson classification system, and describe the subaxial and cervical trauma based on the mechanism of injury. The novel subaxial cervical spine injury classification system, SLIC, and slice as proposed by the Vaccaro et al. In a recent attempt to use the point-based system in the classification of subaxial cervical injuries. And it is important to note both mechanism of injuries and the morphology, even describing a cervical injury, the determination of the vertebral instability and the integrity of the or we can say disco-ligamentous structure are paramount when considering the surgical therapy. Regarding the pathophysiology, the subaxial spine is the site of the majority of the cervical fracture and dislocation, and being accountable for 65% of all cervical fracture and 75%, more than 75% of all cervical dislocation. Numerous types of fracture or fracture pattern exist and can result from the pathological stress and are placed on the bony or ligamentous components of the vertebral column. These can be as a result of hyperextension or hyperflexion, or axial loading or rotational force, and the morphology of the fracture will often elucidate the mechanism of injury. Trauma account for a majority of fracture in younger population, and ground level falls account for the majority of fracture in the elderly. Subaxial spine fracture is associated with the high risk of the non-contagious fracture on other areas of the vertebral column, and the provider should have the high suspicion of non-contagious fracture on initial assessment. Several specific subaxial cervical fracture exist and are described in the literature. As you know, the spinous process avulsion, hyperflexion, often seen is the context of trauma, result from the shear force causing sudden strain on muscular attachment to the spinous process at this level. Avulsion of the C7 spinous process, commonly referred as a clay shower fracture, is a result of the sudden trapezius contraction on the context of attempt to eject stuck clay for the end of the shower. Teardrop fracture, or the hyperflexion axial loading fracture of the anterior inferior vertebral body, producing a small chip appearing as a teardrop or the lateral film, and result from compression in the setting of flexion of the vertebral column. It is an unstable injury with concomitant fracture and disruption of anterior ligamentous complex. Posterior ligamentous structures are frequently injured as well, and usually accompanied by the retrolisthesis. Here. So, as you know, the retrolisthesis of the anterior vertebral body at the level of the fracture. A more benign form of this fracture, called an avulsion fracture, and result from the hyperextension injury. An avulsion will present without malalignment of the vertebral body or soft tissue swelling. An uncomplicated avulsion fracture spares the posterior ligament complex and usually a stable spine fracture. But the quadraangular flexion plus compression plus axial loading, oblique fracture vertebral body from the anterior superior margin traveling to the inferior end plate. An assessment of the ligamentous structure is key to determine stability. Wedge is a kind of a fracture. Again, there is a flexion plus compression, and the fracture of less than 50% of the vertebral body and without disruption of the annulus or posterior ligament, and typically a stable fracture pattern. Burst fracture, again there is a flexion, compression and axial loading, and this fracture vertebral body ranging in a degree of comminution, and this is an unstable fracture pattern with disruption of the anterior and the middle column. Neither anterior nor posterior longitudinal ligament are intact, and repulsion of the content into the cord and subsequent disruption are common. This burst fracture and quadrangular fracture mechanism of injury is same, such as flexion here, there, and a compression in both, axial loading in both. So the quadrangular and the burst fracture are in that regard are similar. But an oblique fracture vertebral body from the anterior superior margin traveling to the inferior end plate, and the assessment of the ligamentous structure is key to determine stability. This is the difference where the quadrangular and burst. Burst has both posterior longitudinal ligament and the anterior longitudinal ligament are damaged and not intact. So this is the little or major difference in both of this. In subluxation, distraction flexion may present with an anterior and posterior subluxation from the fracture of the vertebral body, but it also accompanied with the disruption or fracture of at least one facet or both facet joint, and result from the study by the White and Punjabi demonstrate both anterior translation of the vertebral body is less than 3.5 millimeter, or angulation of one vertebral body in relation to the next and is more than 11 degrees, so indicate the mechanical instability. So here you have to understand the subluxation. When we use the subluxation, is a distraction, flexion, and may present with the anterior and posterior subluxation from the fracture of the vertebral body, but is also accompanied by disruption or fracture of at least one facet joint or both facet joint, and result from the study of the White and Punjabi demonstrate the anterior translation of the vertebral body more than 3.5 millimeter, or angulation of one vertebral body on relation to the next is more than 11 degrees, and indicate there is a mechanical unstable or unstable fracture. In that regard, wedge I already mentioned in front of you. This was here the subluxation is a distraction here, and this wedge is the flexion and compression. So the wedge fracture is less than 50% of the vertebral body without disruption of the annulus or posterior longitudinal ligament, and this type is called wedge. Is considered a stable fracture, but again the subluxation is considered mechanically unstable fracture. Facet fracture is extension, compression and rotation, single or multiple fracture through the articulating facet or facets, and represent an unstable facet. So when the facet joint injury is happen, one or both, you have to consider this is the unstable kind of fracture, and and the mechanism of injury here: extension, compression and rotation. Traumatic spondylolisthesis, this is the extension and axial loading and anterior displacement of the vertebral body as a result of single or bipedicular fracture, and associated with the pars interarticularis, and the anterior element shift forward and the posterior element are disrupted. Thus is an unstable fracture concern, and definitely this must need the treatment. And again I mentioned you that the spinous process avulsion, usually hyperflexion, and often seen in the context of trauma and result from the shear force causing sudden strain on the muscular attachment to the spinous process at this level, and the avulsion of the C7 spinous process, commonly referred as a clay shoulder fracture, and is a result of sudden trapezoid contraction in the context of the attempt to eject stuck clay from the end of the shower. Teardrop, I want to repeat it because the hyperflexion and axial loading and fracture of the anterior inferior vertebral body, producing a small chip appearing as a teardrop or a lateral film, and results from the compression in a setting of the flexion of the vertebral column. This is an unstable injury with concomitant fracture and disruption of the anterior longitudinal ligament complex, and the posterior longitudinal structure are frequently injured as well, and usually accompanied by the retrolisthesis of the anterior vertebral body at the level of the fracture, and more benign from its of this fracture called the avulsion fracture only. So I tried to explain multiple times this thing. Definitely when you listen, definitely you will understand. Management when deciding and treatment regime, there are many variables to consider. It is important to consider the neurological examination of the of the patient, as well as type and the resultant mechanical instability of the fracture, and are coexisting injuries to the discoligamentous complex. A treatment option can range from a rigid external immobilization HelloVest to surgical fusion with or without compression of the neural element. External immobilization with the help of the HelloVest, useful in patients with non-displaced stable fracture and useful as a bridge to the surgical treatment. But the surgical correction is indicated for the unstable fracture, and considered include the anterior versus a posterior approach, decompression of the neural element, if indicated, instrumentation with the bony fusion. And here the surgical technique, which is very common, very popular, everybody knows very well, this is called the anterior cervical discectomy and fusion. I want to explain a little to you, and which is we are also calling this ACDF. The patient is placed in a supine position. Intraoperative X-ray or fluoroscopy may be obtained at this time to confirm adequate natural positioning of the cervical vertebra column, and 3 centimeter transverse or linear or oblique incision is made at the desired cervical level, which that the medial aspect is located at the lateral edge of the trachea, and the lateral edge is marked by the sternocleidomastoid muscle. Using blunt dissection, the platysma is exposed and dissected through to expose the deeper tissue layer. Once the sternocleidomastoid muscle has been identified, laterally bluntly dissected toward the midline with care to stay medial to the carotid sheath. Use the hand-handled Claward's retractor to full aside the lateral strip muscle and the medial soft tissue as needed. Again, blunt dissection is used to expose the anterior longitudinal ligament and anterior cervical spine. Define the anterior longitudinal ligament, the bilateral longus colli muscle, and anterior cervical vertebral body. Mark the exposed level and confirm the location with intraoperative X-ray or fluoroscopy, and using careful monopolar electrocautery, free the longus colli muscle bilaterally to allow the placement of the radiolucent cervical retractor system, and if necessary expand the field superiorly or inferiorly to assess all relevant level, and after excising the annulus, a series of curate and ronger forceps are used to remove the disc in its entirety, and the uncinate process should define the lateral limit of the discectomy, and the osteophyte should be removed with either a high speed drill or ronger forceps. It is important to remove the often adherent cartilaginous superior and inferior end plate, as failure to do so may inhibit bony fusion. Foraminotomy may be considered at this junction. Indicated, measure the height and width of the with the appropriate size interbody device, autograft and the allograft. Care is taken to measure the appropriate length and width of an anterior cervical plate. Place the plate over the interbody implant and bridge the vertebral body above and below. Drill and screw the plate in a place and engaging the lock after finishing the insertion of all screws. Ensure hemostasis is achieved and placement of the post-surgical drain may be considered. Meticulous closure is performed. Complications such as the recurrent laryngeal nerve injury may be transient or permanent. Post-operative hematoma, injury to the carotid sheath or its content. So everything should be considered and take carefully to avoid any kind of injury, dysphagia, dysarthria, wound infection, long-term or long-term, we can say the subjacent or the adjacent level disease. These are all the possibilities, but I just want to present this case in front of you. Just a humble reminder, I hope you will like it. If you like it, please share it, subscribe and support us. Thank you so much.